So next up, we'll just roll right in. We have Andy Novick, and we're going to see if I get these bullets right. And Andy, feel free to correct me or fill in. I'll just start with a really brief introduction. Um, Andy completed his undergraduate training at UNC Chapel Hill, as well as got a bachelor's in science in pharmacology and toxicology at St. Joseph's University, Philadelphia College of Pharmacy, which explains why my advisor, a pharmacologist, was so disappointed in me coming in his footsteps. Um, Andy got his MD, PhD in medicine and neuroscience at the University of South Dakota and Sanford School of Medicine. He completed his residency in psychiatry at the Warren Alpert Medical School at Brown University. He's now at the University of Colorado Anschutz Medical Campus, where he's an assistant professor of psychiatry as well as the medical director of the CU esketamine program. His research spans reproductive psychiatry, we're not done yet, we're still going. um, Reproductive psychiatry, neuroendocrinology, psychopharmacology, and translational neuroscience. You can find publications on mindfulness, postpartum depression, treatment-resistant depression, SSRIs, antidepressants, psychedelics, so widespread of expertise. He's authored, I think, 38 PubMed indexed publications, run many clinical trials, and I'm just going to cap it at that. I'm so grateful, Andy, to have you here. It's just such a treat. Thank you.
Of course. Yeah. Yeah. Great to be here. I should probably just start by putting up my usual just the disclosure slide.
Cool.
So I'm a as an employee of the University of Colorado, I technically am a state employee. And then I also, receive part of my salary from the National Institutes of Health. Um, and and this didn't used to be like that big a deal, but now people who I have to be careful, I guess, and really explain that these are my opinions, and I'm not representing the National Institutes of Health, so they don't take like my funding away. Uh,
Beautiful.
but other than that, yeah, but I don't have any other kind of like real conflicts of interest. I don't receive money from any sort of pharmaceutical companies. I don't own stock in anything. My wife, who's here on the Zoom, she doesn't own stock in anything. And yeah, and so while we all have our biases and stuff, I don't have any direct kind of financial relationships that I would need to disclose. So,
Beautiful. Thank you.
yep.
Um, so I thought I'd start. I wonder if you could share a little bit. I just kind of hit the bullet points. I
Yeah,
wonder if you could maybe fill in some of those gaps and just share a little bit about your background, kind of your undergraduate, graduate, postdoc,
sure.
yeah,
Yeah,
training.
yeah. Yeah, my interest in this stuff actually, started, when I was in high school. I think, I was a kid who was trying to figure out, what I liked, what I was good at, what like my niche in the world was going to be. And I was fortunate enough to go to a high school that had a very extensive library, and started reading, quite a bit about drugs, and not in the way that you would think like most adolescents would be interested in drugs. I started reading a lot of books about the history of psychopharmacology, also various like the development of analogs of our endogenous sex steroids, which led to very fascinating and important drugs that we have today, from hormonal contraception to anabolic androgenic steroids to treatments for, menopause. And I thought this was just the coolest stuff in the world. And yeah, and then eventually, yeah, decided that that's really what I wanted to study in undergrad, and yeah, and kind of eventually ended up at this place in Philadelphia called the Philadelphia College of Pharmacy, which yeah, it was the first college of pharmacy in the United States, and we had and similar and yeah, that was a place where I just got to get a lot of really cool experience with things. Besides kind of getting my first experience doing actual neuroscience research and injecting rats with antidepressants, and I there was also yeah, once again, this very kind of like niche library of just every book about drugs in the world. Um, uh, and um, and one of the books that I actually was really influential in the LAC. So it was this one. Oh, hold on. Right. Oh, I might not be able to find it. There it is. Okay. So this one. So if you can see it, it's called Drug Sudden Setting. It's by a guy named
Ooh,
Norman Zimberg. So a lot of people right mentioned in the psychedelic field, like mentioned that phrase sudden setting. I would venture to guess that not a lot of them know where it actually comes from. And it's actually this book right here. And it was called The Basis for Controlled Intoxicant Use, and talks about why is it that some people use not just psychedelics, but all sorts of drugs, and some people have major problems with them and other people don't. And introduces and really kind of goes into the psychology of setting, why these things are important, how you actually manage them, and it was based on this huge research project that these guys did. One of them being a name that probably people recognize, Dr. Andrew Wow, who, my understanding, he's kind of gone out of favor
yeah.
in recent years. But anyway, we can talk about that some other time. Anyway, so yeah, no, that was a big experience for me. And right, yeah, then I met this woman from New Zealand and this guy from Australia at a conference once. And they were doing this really cool work in like adolescent rats about social stressors and development of their brains. And I thought that was really cool, and that's how I ended up at the University of South Dakota, and that's right, where Brenna and I met. um and um and yeah, I think the important thing during all this time, I really wanted to actually become a psychiatrist, and then eventually went to Brown. And it was there that a couple of things happened. One is going through psychiatry residency is just this ongoing experience of I guess the nice way to put it is 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 being frequently humbled. Like, I think the more reality of it was kind of just getting a kick in the face all the time. Like, as soon as you developed confidence and you thought you had seen things and you thought you were getting good at treating people, you would constantly be just barraged with how severe and difficult these disorders are to treat. And the wide variety of things that you see, and and how difficult it is to get proper diagnosis of people, the variations that we would see in drug response, and and some of the disappointing effects that we had with our drugs. That definitely shaped things. The other thing that really shaped things when I was in residency was we had a very strong program in reproductive psychiatry at Brown. They created what was called the first mother-infant hospitalization program, with this idea that, if women in the postpartum period are having psychiatric issues, it might be important for them to actually be with their infants. It sounds like a real obvious type of thing, but was not common until until really the 2000s. And that was the environment that I was trained in. And I got got to be around a lot of really smart people in the area of reproductive psychiatry, and then eventually met this woman who came and gave a talk. Her name was Neil Epperson, and she had just taken the chair at the University of Colorado. And we started talking, and I thought her stuff was really cool and amazing. And she invited me to come out, and that's where I am today. I think what happened, and just so yeah, I know I'm going on and rambling about my experiences, but we can get to other stuff. But yeah, around 2021 or so, it became really obvious that psychedelics in particular were going to be a thing in psychiatry. And I started getting kind of really worried about that I was going to see a future with these things, in which, as a psychiatrist, I was going to be treating people when things went wrong. And and being kind of on the passive end of things, and just like it's like, oh, I'll get to see like the fallout, like when this stuff
Mhm.
like just doesn't go right.
Mhm.
That was not very appealing to me. And that if I want to be involved in this, like I want to be out at the forefront. And so I convinced my chair to let me set up our infrastructure for administering psychedelic drugs within the Department of Psychiatry. And like right now, I'm part of various clinical trials doing that. And yeah, and so that's basically my story.
Beautiful. Thank you.
Sure. Yeah.
So that kind of feeds into the next question that I was going to ask was, your background is kind of in antidepressants,
Hmm.
SSRIs, and what
Yeah.
really drew you. Maybe I'll actually start with that. So, and you kind of answered this as well, but what really drew you to the intersection of kind of neurobiology and reproductive mental health?
Yeah. I think that's an interesting question. Um, I would say like sometimes it's hard to answer these questions, like because the truth is that like all of us, like in the things that we go into, like it's always due to this mix of like both like conscious and unconscious, like kind of like personal experiences, kind of like luck of like where we were, and we try to tell ourselves like this narrative of like this is why I do what I do today, right? Like and it's always like a bit more complicated.
Yeah.
That said, like it said, like yeah, I think right, like I had this ongoing kind of like fascination with drugs, and and specifically drugs that like influence people's mental state, and was able to help them. Simultaneously, I had like yeah these really positive experiences with in reproductive psychiatry and taking care of women who like were having issues with anything from like problems related to their menstrual cycle to psychiatric issues in pregnancy or the postpartum period to the perimenopausal transition, and had a lot of mentors who really supported me in that interest, and which I think was essential. um, and um, and also I think there was always the strong belief, and not belief really, but fascination with the idea that like our sex steroids in particular play a really important role in shaping both a lot of the really cool and positive things about human nature, but also can contribute towards like when things go wrong with our mental state. And yeah, and in reproductive psychiatry, you really get to be like at the interface of hormones, drugs, social experience, social attachment. And you get to do something that a lot of people are uncomfortable with and scared of, and it's very reinforcing when people have been to like other providers, and like and they are scared of treating a pregnant woman, and then they come to you, and you're able to just by taking an interest in them and kind of knowing what you're talking about, and wanting to help them, they feel like extremely comfortable, and they are very grateful for that. So that's been I think yeah, I've just had positive experiences. Yeah.
Beautiful. Thank you.
Mhm.
Um, okay, I'll get right into like the more juicy stuff. So
Sure.
maybe let's talk about the clinical terrain a little bit. And
Sure.
you have this background in SSRIs, and now kind of I won't even say stepping into, I'd say you're in the
Mhm.
psychedelic
Sure.
assisted therapy
Yeah.
space. How do those two medicines and therapies differ? And I'm going to offer like a fork of questions here. So maybe one in their mechanisms, and then also
Mhm.
in their kind of therapeutic trajectory. And
Yeah. Yeah. Yeah.
thank
Yeah.
you.
So what I can do, yeah, I can kind of, I can share with you guys, it's, like, I think some fascinating quotes that get at this a little bit. And so, like, yeah, I can share my screen here. Hold on a second. Mhm. Okay, let me go back to this. All right. Okay. So I think you can share with the screen now, the
Yeah.
slide, right?
Yep. Yeah.
Okay. All right. So this is a quote. This is the dedication to this book here. This is called a book called Drugs and Psychoanalysis and Psychotherapy. And this was always very inspiring to me. It's called, and the guy says, to the psychiatrists of the new generations who will understand a sound psychiatry must be securely based on a sound psychology, which is the physiology of the mind, but will not on that account neglect the study of the physiology of the brain or disdain to exploit it for the benefit of their patients and their science. And so this was written in 1962. And so you might think that, like, a guy like talking about, like, drugs and psychotherapy in 1962 was probably talking about psychedelics. There was a lot of that stuff going on at that time in which psychiatrists, like, and various psychologists were starting to experiment with these drugs, and utilizing it in the context of the psychotherapeutic techniques that they knew about. Um, that said, this book was not about psychedelics, and it doesn't mention psychedelics even once. Instead, what this book is about is the fact that around 1962 was really the heyday of conventional psychopharmacology, in which you had, like, in which you had drugs, antidepressants, as well as antipsychotic medications, as well as mood stabilizers, just coming out like one after the other. And you started seeing this split within psychiatry, in which you had these psychoanalysts on one side who, like, they were kind of doing what they were doing, and all of a sudden you have these drugs come out and people are getting very excited about them. We're starting to see kind of, like, the birth of psychopharmacology and really neuroscience within psychiatry, and there's this huge schism. And Dr. Ostow here, he was just a maverick and a champion for the idea that, there really doesn't need to be this schism at all. And he started administering these, like, all these antidepressants and these antipsychotics to his patients in the context of doing very intensive psychoanalytic psychotherapy. And he has all these case studies that he did, and he was trying to figure out, like, what these drugs did, like, on the basis of they're not just kind of like, oh, does it improve someone's depression or schizophrenia? Like, what is it actually doing from a psyche standpoint? And what does it do? And what are the reciprocal interactions, both the effect of the drug on the therapy and the effect of the therapy on the drug? And this is, and he also points out that he strongly believed that these drugs should not be utilized in the context of just kind of monthly appointments, but instead, right, like, they should be like an ongoing kind of, like, relationship with a therapist, very similar to how, like, we talk about kind of psychedelics today. And he talks about, like, and a lot of the language that he used has been co-opted by the psychedelic community, by the modern psychedelic community. And because all this stuff, like, stems from, like, psychological knowledge that, had been started, by Freud and William James and all these other people. And it goes to show you that, that a lot of the context in which we think about, like, conventional antidepressants today, is very different, compared to how, like, a lot of people were thinking about it in the past. And it's kind of a lost art, in that, these drugs are not just, like, things that we sling, to, like, millions of people. And we kind of just, like, give them prescription and never really see them again. That, that there was really a group of people, and there still are, I would say, who were very fascinated in how these, drugs work and how to optimally utilize them. And then I want to share what is a quote that I use to teach my residents about antidepressant response. And so this is one of my favorite ones. And so
You just happen to have this PowerPoint up on your laptop at all times, right?
because I end up sharing, because there was a while when I was like, oh, I need to get that quote for you guys.
Yeah.
And I was like, give me like 10 minutes and stuff. And so I, like,
Yeah.
eventually, like, have to, like, I eventually created this. Yeah. And so, like, so this is he goes, I was crossing a bridge on Fraternity Row when it hit. First, I smelled burning wood. I stopped dead in my tracks because I had a rush of pleasant memories from childhood. I noticed the breeze through my hair felt nice and not like something to be observed or analyzed. It was small, but it was everything. I stood on the bridge for several minutes, taking it all in, the bushes, the trees, the dirt, and the sky. I watched the smoke rise from a chimney, But I didn't ask myself why have a fire on a Sunday morning like this. Suddenly I had it, the epiphany. The change I had been looking for was emotional, an uplift in my spirits, maybe even an answer to the big one. What is the point of life? But that wasn't it. Rather, the difference was essentially physical. It was like my mind's eye had had double vision, and now my sight was clear. Where before I had this consciousness of floating above life like a passenger in a jet, watching the patchwork of earth slide beneath. Now I was suddenly on the ground, where the patterns of life were not visible, but the feeling of being part of it was once again in my bones. If you saw me on that day of the bridge with the wondrous look that I had on my face, you might thought I was seeing God. And so I bring this up to my residents is like, it's like, hey, like, obviously this is an amazing writer here. And like, right, he uses a lot of kind of like, really great language and everything. But this is really what we're looking at when we talk about recovery from depression. In that, we're looking to get people, right, like that they are no longer just like floating above things. They're no longer in their head, but they are on the ground feeling a part of things. And once again, like you would think that by the description of this sounds like a college dude using a psychedelic, right? Yeah,
Yeah.
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 Okay. All right. Once again, you'd be wrong. All right. For weeks, I munched it all off, hoping to feel better again. One day I woke, took a shower, and headed to class for the first time in weeks, right? And so we are talking about the time frame in which these drugs tend to kick in. And right, and this is a description of things. And yeah, like when you've prescribed enough drugs, like enough of these drugs to people, you realize that yeah, no, a lot of them, right? Are they talking about that they like yeah, like oh my gosh, like I was on a bridge and like you would have thought that I was seeing God. No, but what they talk about is that they feel again like themselves and they feel like they're a part of things and they feel like they're like finally able to no longer see kind of like it, to no longer have the types of like it just negatively biased emotions and memories that they used to and things switch and right, and there's a lot of really cool literature on this about changes kind of in emotional processing that happen with traditional antidepressant drugs that you wouldn't think that like that you wouldn't think occur based on like how we have kind of created this false dichotomy between kind of like psychedelics on one side and conventional antidepressants on the other. And the truth is that these drugs actually work rather similar. There's a ton of differences between how they work, but there's also a lot of similarities. So usually like we think about like, oh, okay, so psychedelics, classical psychedelics hit the 5-HT2A receptor, and that's where the money is, and that's what they're doing. And there's all sorts of magical things that happen once you hit that 2A receptor. We think of these kind of SSRIs. Well, okay, we're inhibiting the serotonin reuptake pump, and we're causing kind of this like steady increase kind of in serotonin throughout the brain. With if anything, it seems to be probably down regulating like the 5-HT2A receptor. And so like wouldn't you have kind of opposite effects like that go on? And the truth is that you probably don't. And the reason for that is that recent data has showed that yeah, there's probably something to hitting the 5-HT2A receptor with psychedelics, and yeah, there's probably something to kind of hitting the serotonin transporter with things like SSRIs. But where things are happening actually is that both of these drugs are direct agonists, meaning that they hit the same receptor, which is called the TRKB receptor, which is a receptor for a neurotrophic factor, which means a growth factor in the brain, that allows for this word that has become more common in today's culture called neuroplasticity, or the ability of the brain to change. And so you have this common, not only do you have a common final pathway between these drugs, you actually have a very common direct mechanism of action in how they're working. Um, Now, right, like different drugs do very different things. And like, yeah, I'm not trying to say that these are equivalents in any way. But in terms of the and like right, they can have all sorts of risks and side effects that are sometimes rather different from one another. But if we're talking about the common pathways and how people actually recover from depression, we're probably seeing some probably more similarities than probably differences.
Beautiful.
Um,
Thank you.
yeah, sure.
And I'm kind of embarrassed. This is like a pretty ignorant question, but
Yeah,
it's been a minute. So the TRKB by memory can also be stimulated by BDNF and
correct.
can also stimulate BDNF. Is that correct, or am I off on that? I think I'm maybe off. It can just be stimulated.
Yeah, that's an interesting question, and like, yeah, no, the kind of like that pathway, I admit, like, is not like, my, I wouldn't call like myself like, like a
Yeah, yeah.
definitive expert in it. But no, that is true that like, yeah, that there's, I believe there is a bit like, so if you hit the receptor, there's two things that happen. One is that you actually induce kind of the growth of neuronal connections that you get with BDNF. And two, at least kind of like with these drugs, with like, conventional antidepressants, LSD, psilocybin, ketamine, you're also encouraging additional BDNF to bind to the receptor. And so it's kind of like a twofer, like, right? Like you're both hitting the receptor and actually causing all the fun stuff that happens with hitting that receptor. And you're also kind of encouraging more of like endogenous BDNF to bind as well. Yeah.
Thank you. And then this is another, like I should know, pretty ignorant, but again, my understanding is that the TRKB receptor can stimulate both neurogenesis and neuroplasticity. Is that accurate, or is it just
Oh,
neuroplasticity?
that's an interesting. Yeah, that's a funny. Yeah, like I think
I
there's
obviously have a certain perspective.
yeah, like yeah, there's a bunch of different controversy about this, and and we were actually talking about it. Like I remember like several months back. Yeah, the extent to which kind of like, yeah, neurogenesis is or isn't happening in the adult brain. That in neurogenesis meaning kind of like the actual like proliferation of new neurons, right? Like, like can that happen? And I think right that like kind of things went in the direction of like, oh, okay, we definitely see this in like rodents and stuff, and that's really cool. And we thought like, and we think it can happen in humans as well. And then there was kind of like this backlash to that about like, oh yeah, no, it's probably not happening like in humans at all. And then if you talk to like kind of like the people who are kind of like at the like the inner circle of this type of stuff, they're going back now to like, no, we're pretty sure that actual neurogenesis and like creation of new neurons can continue to happen within the human adult brain. It's something
Yeah.
that's really hard to study and really hard to.
Yeah, I was just going to say that's kind of the limiting. We have this conversation in my class all the time. My students are like, well, why don't, it's like, well, we don't maybe have the tools yet to
Yeah.
fully study them.
Hmm. Yeah.
Um,
Yeah,
cool.
but even if it's not happening, like I think what's really important to know is that like, when we talk about something like major depressive disorder, um, and I thought about like I was explaining this to a patient like just yesterday, and I thought of this great, very Colorado-esque analogy that the problem with major depressive disorder is that you end up getting kind of you end up getting input from your environment and like and people who are depressed, right, like they see someone walk by who like just kind of like walking by, and they assume that person like their brain is basically telling that person is angry or sad, like or possibly angry at them. And then there are these like very well worn tracks. It's basically major depressive disorder is basically like only having access to one trail here in Colorado, right? And like no matter where you try to get on, you are going to end up in the same place. And that's what major depressive disorder is like. A really sad thing to live in Colorado and like to only be able to go hiking on one trail.
Unless
And
it's Lion's Lair, and then it's fine.
what's that?
I said, unless it's Lion's Lair, which is my
Oh,
favorite.
okay. Okay. I don't know that, but I'm gonna yeah, it's obviously I have people who have their favorites here.
Yeah,
And
yeah.
so um uh and right. And so like essentially like yeah, like, like there are the potential, like, for other trails to be made and stuff, and they already exist in your brain. But like we have just, but and the important thing is that we start making actual paths to other trails, and like,
Yeah.
and whether like kind of, and because right, like the quote I gave you, like, right, like you have pleasant memories from childhood, those are inaccessible, like, when someone has depression.
Yeah.
And so, and yeah, and like kind of the fact that, right, that you would be a college student who's like on your way to class, and you smell a fire, and that leads to pleasant memory from childhood, like, right, that's what recovery from depression likes, and kind of building these new pathways and these new trails that may already be there. And that's why people who don't have a history of significant adverse childhood experiences do so much better
Mhm.
with psychiatric treatment. Be it like, like psychedelics or conventional antidepressants, is because they already have, we don't need to kind of like create as many new trails. We like have ones that are already there. Yeah.
Beautiful.
Um,
Thank you. So I guess maybe the next question, Erica Zelfan presented earlier, and
yeah.
she kind of presented on like using all the tools in the toolbox as a
Yeah.
provider. And so I think I'll maybe go with that analogy. And I kind of know, we've kind of talked about this before the summit, but I wonder if you might share a little bit of like how you view, antidepressants and psychedelics, or ketamine specifically as like, if these are different tools or different crayons, what are they best suited for, maybe, or how do you
Right.
actually put
Yeah.
those together?
Yeah. So that, I mean, so yeah, like that's the $1 million question. And but I guess like moving back a little bit is that, right, like, when you like when you're in like the position that like I am, when like, you just end up seeing, like, right, like such severity, and the idea that like we would want to like limit ourselves at all, like to any kind of one tool, like would be ridiculous, and would be kind of very like limited. That, in the end, like, what is, I think, like rewarding for me, and is rewarding for, at least for kind of like the psychiatrists that I work with, is getting to see like people recover, and right, and we want to throw everything that we have at them, to get them there. And usually the limitation to that is like resources, right? Like we just don't have, like, people don't have the resources, and we don't have the resources to do all the things that we would ideally want to. That said, I think but you're getting at the question of like, yeah, like how do we kind of utilize, and how do we think about like the use of conventional antidepressants with these more advanced pharmacotherapies like psychedelics and ketamine. And I think that raises two things. Is like one, a lot of times what you have with treatment resistant depression is that people like are already like on a bunch of medications, um and and what happens with a lot of these patients is that they are not doing well at all. However, they would be doing a lot worse if they weren't on these medications.
Mhm.
And we see this in clinical trials all the time, in which, right, like, in order to isolate things, we make sure that we like taper people off medications, and
Mhm.
all of a sudden, like, that's the, like, people realize that it's like, oh my gosh, these were really helping me.
Mhm.
Now, like, there is the concept of kind of like antidepressant withdrawal and discontinuation syndrome and stuff, and that's a whole other issue, to get at. But right, like, there's no doubt that we start to see some of these benefits like emerge, and people kind of realize, after we try to get them off of them. And a good psychiatrist will get people off meds if they're not working. And so I run into this all the time, in which I'm treating a patient, it doesn't seem like something's working, we give it a try, and then we kind of come off of it. And there were kind of these very non-specific type of things that aren't necessarily captured by our traditional depression measures and sort of benefits that they were getting. So it's a kind of unfair and or just not a great idea when you're dealing with people like who are extremely functionally impaired and also at risk of death by suicide, to make them come off of medications before they can try an advanced therapy. And so that's, one thing that like I felt really strongly about. Like when I got the opportunity to design my own trial, I was like, yeah, we're not going to make people come off meds. And we've gotten kind of more data on this, that not only was it ridiculous that people thought that, oh, by combining conventional antidepressants, with the exception of MAOIs, that we're going to run into serotonin syndrome, which it is which was highly theoretical to begin with. And as we got more experience, just doesn't happen and doesn't make sense pharmacologically. And then also that this idea that by being on these medications, you are gonna somehow like blunt the efficacy or the experience of it. And we still need more data on this, because so many people and so many whether it's pharmaceutical companies or whether it was philanthropic designed or funded trials, or academic funded trials what I do, that I think we were scared to do it. And so we need more data to suggest oh, does this actually interfere with things? So a lot of the data that we have so far suggests that it probably doesn't, as much as we thought it did. And so yeah, though I'm a big believer in that we should be combining treatments. We should be once again is utilizing all the resources that we have, everything that we have in our book, and and that a lot of times this is going to include kind of prescribing conventional antidepressants with psychedelics. Another interesting tidbit that a lot of people don't know about is that in the MDMA trials for PTSD, what you ended up seeing was that after people went through the MDMA protocol and stuff, a significant more of individuals who got MDMA versus placebo ended up deciding to go on conventional antidepressant treatments for some reason, as if it kind of opened up kind of this, who knows, it's all speculation, but that was very hard to tease out. And to what extent was it the MDMA, to what extent that they started seeking other treatments down the road, and that those were now effective and stuff, that they saw really good relapse prevention after the fact.
Yeah.
And so, yeah, I think right that, also another big thing about, I guess that brings up another issue, that as much as we would love to think that that we have treatments that are one and done, kind of a cure, oh man, major depressive disorder is a bitch. This is it hijacks your brain, and it will be fighting to come back. Right? That was the default position of your brain, and to get it to just go away and never come back is really difficult. And so the idea that that we can kind of just give one person one psychedelic experience and they're going to be good for the rest of their life is we'll see about that. And also I think we have to be careful the extent to which we don't know a lot about doing ongoing repeat doses of these drugs. And yeah, and I think that a lot of the experts that kind of that from the underground have told me, they're yeah, maybe twice a year for most people, it's probably
Yeah.
a
Yeah.
good once you start getting beyond that, yeah, I think there that you get a certain type of phenotype develops, and that can for some people isn't always useful. Yeah.
Yeah, beautiful. So
Yeah.
I've got kind of a to the heart jugular question, but I'm gonna ask a peripheral question first.
Yeah.
Um, because you mentioned something that I thought was really interesting, and you said, oftentimes we might have a patient on an SSRI or an antidepressant and we don't think it's working, but then when we take them off of it, we find out that it was having these other effects that we maybe hadn't been accounting for. And
Yeah.
Erica Zelfan said something similar in her talk about psychedelics, which what I asked her, what should research, what would you like to see research account for in
Yeah.
the psychedelic space? And she said, well, I'm trained as a naturopathic practitioner, and so we really view root causes. So you can say like, oh, psilocybin improves obesity or binge eating disorder, this or that, but often those maybe aren't the root causes. And
Yeah.
so just it was kind of a similar discussion around, maybe these impacts that we might not be capturing always in research. And I'm going to add in another layer onto that, and that's that. My own observation and kind of perspective in research is, I'll just say my own experience as a researcher, is balancing being someone who is highly detail oriented and really attuned to nuance, and then
Yeah.
trying to navigate funding, which is often very limiting, where you have limited resources and you have to just go straight for the thing. And so I guess I wonder in all of that, I wish I had like the question beautifully phrased, but I wonder if you can maybe just speak a little bit to that of like, what are you seeing when you take folks off of antidepressants that you're like, oh, we maybe hadn't accounted for that, and if there's
Yeah.
anything else you have to add on that.
Yeah. Yeah. So, yeah, so I think in general, right. So I guess I will kind of like go a little bit like on my rant about like the concept of root causes, which I've discussed with you, Brenna. Like,
Yeah.
that these are highly heterogeneous, like, like very complex disorders. I think anyone who kind of like says that like who like says that like we're getting to the root cause, probably like either at least for me as like kind of like a scientist and stuff, like probably isn't using that phrase correctly. Or more dangerous, right, are people like who are highly narcissistic and are saying that they know the root cause to something, or people who are trying to exploit you for your money. And I think it's very important that like, yeah, that like, right, like, hey, like in the end, like these things are so complex, and right, and like and that like and the best that we can do is really kind of get at like making people feel better, people like making people like do the things that matter in life, which is functioning in a role that is meaningful for them, like whether it is through their work, in their relationships, like as a parent, as a spouse, as a partner, and yeah, and that like I think like that's like good enough, and like not getting caught up as to whether we are addressing like any sort of like root cause or not, because like right, like you tell me what you think the root cause is and I will poke a million holes in it, right?
Mhm, mhm.
That being said, yes, so what you should know is that right, like overall, like in so the FDA, out of like kind of out of a necessity in some ways, in order to kind of protect the public and to get drugs that like are going to be kind of effective, right, had to be like, hey, if you want a drug approved, it has to be for a specific indication, and it has to be like proved effective based on measures that we have all agreed upon, right? And so all of our drugs are studied in this context. And so, right, we utilize like when it comes to depression, we utilize like these depression measures that were like created in the 70s, actually when kind of the nature of depression was a little bit different than what we see now. And don't capture a lot of kind of like a lot of when it comes to actual function, kind of disability, like right, meaning making, like all of the other things that are really important to people, and that like the things that we want to see when people recover from a mental illness. Now, in terms of your very more specific question about like what do like kind of like I see kind of like, yeah, what is it that like when I take patients off of antidepressants and stuff, and like what do they notice? Sometimes it is just like it is a very kind of textbook worsening of things, right? That we just kind of forgot about, right? Because they were doing so awful while on the drug still, but it was just even worse, right? Like you just think about kind of things like yeah, like suicidal ideation and behavior, other things like right, like people who were losing a ton of weight because they had no appetite at all, and right, if that gets worse, or yeah, very kind of typical kind of depression type symptoms. Um, that said, the other types of things that like yeah that I'll often hear about is yeah, like things, this concept of like of they feel much more foreign to themselves. It might also be that that like yeah, that the individual says that all of a sudden, right, yeah, that the stressors are that they are dealing with are now just so much more difficult. And that's and right, and so when like before it wasn't that big a deal, like not that it wasn't a big deal, but like they were kind of like treading above water, like when it came to like having kind of a crappy job, and like right, like a kid who's kind of getting in trouble at school and everything, like now that is just totally unmanageable. And I think those are the types of things that, yeah, that like, when I do, standardized clinical interviews for depression in my clinical trials, just that's not going to capture it all.
Yeah, beautiful. Thank you.
Mhm.
Okay, now I'm going to go for the jugular question,
Yes. Yeah,
which I think will
definitely.
be the good stuff. And I'm actually just going to frame it really experientially. Um, there was a you don't have to spend too long, I think, on any social media before you might read or hear comments, oh, SSRIs are overprescribed. And you were kind enough to share with me your kind of perspective on that and what
Yeah.
you see as a provider.
Yeah.
And I think that that is just so meaningful. I think it can be really easy to be on social media and I'll name I if I were going to be in one of the camps, I might be in the camp of thinking, yes, SSRIs are overprescribed. And you're sharing your perspective, I thought was really valuable. So I wonder if you might just kind of share really,
Sure.
yeah, what you
Yeah.
see.
Yeah. So I think, like, I think a lot of that comes from my perspective has been is several fold, that like that there continues to be like a major stigmatization of seeking help for mental for someone's like psychiatric issues, um and um and right, like we live in a society, especially here in the United States, where like right, like this place was founded by self-starters, and like we pull it, and like we are resilient and stuff, and like you're supposed to kind of face adversity and get over it, and and everything, and so the idea of kind of like of it's like, why don't we talk about like other drugs that are overprescribed? Why does the New York Times love to talk about psychotropic drugs so much, but they're not talking a lot about other drugs, like, and everything? That we just like love to we just love to hate on these medications. And in no way would I try to advocate that that they don't have problems. I would also never try to advocate that like that or try to put forth like the thing that they are never kind of like used inappropriately. But I think as a psychiatrist, right, like, the people who I see like tend to like have like very severe like, mental illness, and they come to me, and and especially in my field, like, where I'm seeing kind of pregnant women and postpartum women, they are very anxious about like the idea of using drugs. Um, and, um, and right, like, and also, right, like, when I kind of, I think it feels a little there's a disconnect when I hear stuff about things being overprescribed and like things being used inappropriately, And then I see kind of the, a woman in my office who like, right, like I have done a 90-minute evaluation to get a proper diagnosis on it. We have undergone informed consent and shared decision making, and we decide like to actually prescribe this medication because like, she's falling apart, like, um, and, uh, and, um, and yeah, and I think about like both how it feels for me as the provider, like to kind of almost kind of be accused of like that I'm kind of just like a vending machine of drugs, and also how it feels for my patient to basically go back into like a society in which like she's now taking a drug that like other people are stating that is basically like you know like just handed out like candy and overprescribed and used kind of like and that she shouldn't be on, when we kind of did so much education to make this feel less stigmatized. And similarly, usually inherent in the whether it's intended or not, inherent in the messaging that these drugs are overprescribed is usually the message that if only this person would do X or Y or Z, they wouldn't need to be on medication, right? And so you put the guilt on the patient, right? That like this is somehow you are taking a shortcut to things. And if only you had like right, like like in the same way that people make like parents feel guilty and we like and pregnant women feel guilty that they're not doing everything, just people with mental illness that like, oh, like if only kind of like you were working harder, if only you were exercising more, if only you were like I don't know, like right, like yeah, like in psychotherapy more or nicer to your spouse or something, like you wouldn't be on medication. And so I think like that's a little problematic. Uh, and yeah, and so yeah, I think I don't know. There's a lot more I could say about that. Maybe I'll just kind of pause there.
Thank you. I think one thing that really resonated for me around that when you shared it was it's something that just my own personal perspective that I see in eating disorders, particularly binge eating disorder, but also I think in mental health broadly, in that oftentimes I think the people who I hear say SSRIs are overprescribed, and again, like if I were in a camp, it probably would be that one. Um, I don't think that they're overprescribed, but just that's not my own personal path. Um, I think a lot of those people maybe there's like a parsing out of like maybe they don't advocate pharmacotherapy as much. Um, but I think that I may be rambling and maybe I should just like pull it back, but I'll just say I think there's so many other socio-cultural factors to be accounted for in, experiences of mental health and wellness, and to express stigmatization around something that could be helpful, kind of puts the blame on just like one person, like you said,
Right.
this kind of like,
Sure.
well, if you just did this better, that better. And yeah,
Yeah.
I think it misses a lot of the nuance and the
Yeah.
complexity.
Yeah. No, that's for sure. And I think the other issue too is, and this goes back to speaking about like the stigmatization and like and why we're having almost this like so right now like it's really like you go on any social media and stuff, and like right, you see all these tech bros like loving to brag about like the fact that right, they went down to South America, did this ayahuasca ceremony, and like right, like and that was awesome, and now they like are doing great, and like and stuff, and like that's not cool to talk about. It's
Mhm.
not cool to talk about how you went to the nerdy Jewish guy at the academic medical center, and like he prescribed you medication, and like and that kind of like and now like your marriage and your job is saved, right? Like that's just not sexy and not cool, and you're just not getting that messaging, and like and right. And
Yeah,
so
yeah,
yeah, like and I think so, yeah, I think it not only is there kind of like the stigmatization, you're not also not getting the positive press either about it as
yeah,
well.
yeah. And then
Yeah.
I'll just one more like kind of echoing back one thing that one thing that really resonates with me that you had shared was like if you're in the shoes of the provider, right? And
Yeah,
you want to see your patient do well. And if they're doing more severe, and like, I'm not even a, therapist, and I have had experiences kind of adjacent to this with my health coaching clients where like you want to see them do well, they're maybe not doing well. And in the case when you're working with like, very severe depression, treatment resistant depression, there's this other layer of like, if you don't offer something and they do very unwell, that's kind of on, you have to live with that kind of a
yeah,
thing. Yeah. Um,
yeah,
I
yeah.
guess, oh, go ahead.
Sure.
Yeah.
Yeah, yeah, no, no, that's definitely true, and that, yeah, and I think, yeah, yeah, that we really want to do, right by our patients. I would say that, yeah, then that making sure that, that we're giving them like, the most evidence-based options and everything and stuff. And to be clear, like, yeah, like, I think I take these drugs like very seriously, like like, yeah, just recently, I got a referral from like maternal fetal medicine, like about it from a woman who had like a severe like trauma history, was now like extremely anxious during pregnancy and everything. And yeah, and like I actually after my diagnostic evaluation, I was like, I think you're struggling, but you are not in like, in a textbook kind of like depressive episode. And I don't think you have an indication in which we have evidence that these drugs would work. And so I'm not going to just prescribe you drugs right now for the fact, and I think we need to explore kind of non-pharmacological options. And so, yeah, like, I think, right, like, yeah, and this goes to both psychedelics and antidepressants, that we cannot view these things as a panacea, like for every societal ill or just kind of like feeling bad. Or, yeah, and we do also have to be careful about utilizing them for like quote unquote personal growth as well, and talking about like, yeah, where the risk benefits of that kind of come in. And so, yeah, and so like I'm a big believer in that, like, no, these drugs, like whether we're going to initiate psychedelics or conventional, like, medications, like, have to be in the context of like, do we fit, do I have a probability that these are actually going to work with you, or are we just going to be rolling the dice, like, on
Yeah.
something? Yeah.
Yeah.
um,
Yeah. Beautiful.
yeah,
We're at
sure, yeah,
2:09. I could keep talking, I mean, as you
sure.
well know, forever, but I'll just wrap up with like two quicker questions, and one is from me, and one was sent in as a question. Um, so I guess the first one is, are there any kind of like markers? I'm guessing not biomarkers, but maybe kind of profiles of patients who might do better with antidepressants and patients who might do better with psychedelics, or with a combination of both, or are we kind of at that point yet, or are you at that point in your experience with the medicines?
No, what we are trying to do. So, yeah, like, I did do like, so when I was at Psychedelic Science 2025, I did talk about like, yeah, that like our whole panel was on like, this one particular biomarker that we are looking at. And the extent to which, yeah, that we can see it's blood based, which is great. It means you don't have to go into like a brain
Yeah.
scanner
Yeah.
for it. Yeah, the extent to which, right, like, people have responses to either conventional antidepressants or psychedelics. But like overall, like yeah, I, I think I mean, what I would say, like, at this point is like, is there definitely is a very clear phenotype of individuals who are resistant to SSRIs, and like, and and it's one of these things, like, that you kind of like know it, like, when you see it. Like, there is a paper on it. And yeah, and like it's very like these individuals who tend to like have like usually like kind of like mood cycling, like with antidepressants, they also tend to be much more sensitive to like certain types of side effects. And yeah, and those are individuals who, like, I would like, unfortunately, you don't know who they are beforehand until they actually try these things. But like, those are the individuals who are like, yeah, we're done. Like, we're not going to keep banging our head against the wall with these things. And yeah, no, like we need a different mechanism, and we should probably go to like, yeah, something that isn't going to have like, con a continual kind of like, targeting of the serotonin transport. Yeah.
Beautiful.
Yeah.
Thank you so much.
Yeah.
Boy, so grateful for you to just kind of
Yeah.
take the time out of your weekend to be here. Really, really grateful. And if other folks do have questions, feel free to maybe put them in the chat and I can pass them along or, do what I can to answer from the research. But I guess just in a parting, if anyone is a patient or a provider and they want to either get in touch with you or learn more about kind of how to navigate antidepressants, psychedelics. Do you have any kind of tips, resources, contact information?
Oh yeah, sure. I can give you right, like yeah, like not only my contact information, but like yeah, also like right, like yeah, that we have like studies like that like are coming up like always kind of like hopefully
Yeah,
that we will continue to have studies like and I think like there are always a lot of people like um who like sometimes there I think there is I know we have to go, but there is a population like in which like they like yeah maybe they feel comfortable like in being at an academic medical center, and that's kind of like within and my goal is to help those people like yeah like and to do things yeah and do things kind of like the way that we try to really do things like in a very controlled kind of safe environment where you have access to not only a doctor but like a bunch of crash carts around and things like that. And so yeah, I hope that's part of my goal is to give more people that opportunity, and I can definitely provide the resources and contact information about that. Yeah.
beautiful. Thank you so much. There's a Olivia left a comment, not a question, but I could listen to
Oh
Dr.
yeah, that's so
all day.
awesome. Yeah, thank you so much.
Likewise.
That's very
Um,
meaningful.